Started. Okay.
All
All set.
right. Thank you, Nicole, and welcome everyone. This is the Community Health and Access Committee of the Health Planning Council. So happy to have you all here today. I'm Lara Parilla, Community and Academic Partnership Manager with Cuba Health Partners, Cornell Public Health, and the Cornell Center for Health Equity, and also the Health Planning Committee Council President. So it is my honor to introduce our esteemed colleagues, Liddy and Simone, for their presentation today on health outcomes and chronic homelessness. Liddy is the Director of Housing Initiatives at the Human Services Coalition, and Simone Gatson is the COC Housing Specialist and Coordinated Entry Lead at the Human Services Coalition. So welcome to Liddy and Simone, and I will give you the floor.
Hello, good afternoon, I guess it is now. Glad to be here, happy to be here talking to all of you. Some of you have heard from the COC a few times about a few things, and I think this is the first time some people are hearing from the COC. So welcome. This is a presentation about health outcomes and homelessness and sort of what is happening in our system right now. We're open for some questions at the end. You're welcome to also use the chat for questions. We're comfortable with that. And I'm just gonna get started a little bit. So next slide, please. So what is a continuum of care? Continuum of care, which if you live or work in Tompkins County, are part of a continuum of care or covered by a continuum of care. We're called New York 510. And it's a local community planning network. It includes membership from not-for-profits, government entities, people with lived experiences of homelessness, business owners, law enforcement, sort of all of the players you would want to find in a collaborative planning group. And we come together with the mission of making homelessness rare, brief, and one time here in Tompkins County. In order to do that, there are some main things that we do. So one of those things is to organize this community-wide effort to prevent and end homelessness. We act as as a funder. We are the mechanism that a certain pot of HUD funding comes into Tompkins County using the continuum of care. Actually, our funding competition is now open. So if people have any brilliant ideas for projects after talking, let me know. And then we also work to promote access to supportive services and housing. And we do that primarily through coordinated entry, which you'll hear about a little bit later, but also through engaging with health systems and other adjacent people working in adjacent fields. Next slide. So this actually needs to be updated. But this was the membership, the official membership roster for the Continuum of Care in 2023. I think sometimes because people hear from myself and my colleague Simone the most, I think Liddy and Simone are the COC, but we're the staff of the COC, and this group of members make up our governing body and our committees and the people showing up at all the things. So we like to give them a shout out. Next slide, please. So you heard me say in the beginning that our mission, the mission of the Continuum of Care, is to build and maintain a system where experiences of homelessness are rare, brief, and one time. And this slide gets into a little more detail about what the markers for each of those words would look like. So in order for homelessness to be considered rare, basically we're looking to find in our system that we have services that meet the need of all people who could or would take advantage of them. That's a weird way to say it, but basically there are enough supportive services, residential units, whatever it is, to keep the number of people in need of services equal to the amount of services there are in a community. We talk about brief. So you'll hear about this a little bit later too. Unfortunately, in our continuum of care, I don't think we're meeting this metric. Our average length of homelessness is just over 90 days in Tompkins County. But in order for homelessness to be considered brief, we would want people to be exiting that experience of homelessness within 40 days. One time makes sense, right? Basically, if somebody does experience homelessness, we want that to be rare. We want that experience to be brief, and we really only are hoping that a person would ever have to experience that one time. And we measure that one time by less than 5% of people who exit an experience of homelessness to what we call a positive housing destination. So if somebody is leaving the emergency shelter and moving into a permanent housing destination, our hope is that less than 5% of those people are going to be coming back within 2 years. And equitable has to do with our commitment to keeping a very close eye on our racial equity data, making sure that people's outcomes are equitable, that referrals are being made in an equitable way across our system. Next slide. This is where Simone goes, yes.
Yes, hi. So I'm going to talk a little bit about the relationship between health and the homeless response system. I will throw in there that I'm not like a health professional, but really what we can look at is data and the experiences of people in our own system, and see what this relationship kind of looks like. I kind of pulled up some of this data from National Coalition for the Homeless, just because I think it does a really good job of pointing out that homelessness can be caused by chronic health issues, and homelessness can cause chronic health issues. So it is really this vicious cycle of homelessness causing chronic health issues that can lead to homelessness in the future as well. There's a lot of overlap between those two issues, and there's some of the statistics that they pulled in here. Starting from the right, that 36 people experiencing homelessness die each day, that the average life expectancy of someone experiencing homelessness is 50 years, which is 20 or more years younger than the general population. 25% is the number of homeless people who have access to federally funded health care kind of across the country, and over half of personal bankruptcies in the US result from health issues. So there is a pretty significant relationship between health and homelessness, and also like health, finances, and homelessness as well. I like to point out that if you take nothing else from this presentation today, take away that oftentimes when we look at the causes of homelessness, people who aren't in this, like myself and Liddy, most of the time will think of issues like substance use disorder, severe mental illness. But what we see when we actually look at the data is that the main driver of homelessness in this country is not substance use disorder, it's not severe mental illness. Those have little to no correlation with homelessness rates across the country. The real driver is finances, is not being able to afford the cost of housing where you are living. That cost of housing is really associated with the rate of homelessness in a way that no other other way that we slice it, you don't see that relationship. One example that one of our representatives from the United States Interagency Council on Homelessness gave to us was West Virginia, which has one of the highest rates of substance use disorder and one of the lowest rates of homelessness because the housing is low cost. There was another study that found that rates of substance use disorder between the housed and unhoused population were actually very similar. But what was different between those populations was their finances, was their ability to pay for their housing, to have a place to live that has a locked door and a kitchen and all of the things that come with that. So just a reminder that that is really what this comes down to, is the relationship between poor health and finances, or poor health and being able to access resources to help subsidize whatever financial situation someone is in. That said, we're going to go through some of these social determinants of health, because another takeaway from today that I want to talk a little bit about is that oftentimes we rely on these social determinants of health to plan for our community, to understand what the impacts of different resources and issues facing our community are on health, but that a lot of these social determinants of health look completely different when you do not have a stable housing situation to go to. So on the left, I've pulled up some flyers that came from Healthy People 2030. This is, you know, the pretty much understood social determinants of health guidance across the country. So we're thinking about things like employment, you know, we can think about things like pay and job benefits and a safe workplace. But for people experiencing homelessness, they're probably accessing one of the three resources that are on the right to access employment. And oftentimes some of these resources do lead to minimum wage jobs where there's a lot less choice in what really the amount of choice that people who are experiencing homelessness have when it in regards to employment. We think about early childhood development and education. Really the resource that's available for people experiencing homelessness is Head Start through Tompkins Community Action. That's kind of a universal pre-K type of program. Access to health services, again, there's kind of this idea of choice of the kind of health insurance you have, the kind of health worker that you seek, telehealth options, transportation, but really what people in our system are mainly accessing are some of those resources that are on the right over here. So Reach Medical, which is harm reduction medical practice, Southern Tier AIDS prevention, the emergency room when they have a really emergent issue. That's oftentimes where our folks are accessing health services, Cayuga addiction recovery services, health insurance navigation through HSC, and Medicaid cabs. And this is not a comprehensive list, but these are some of like the top resources that people are accessing. And it is a limiting factor in what is available to them as compared to someone who has a stable housing or has stable finances to be able to have more choice in what they're accessing on the day-to-day. Access to foods. So just a reminder that like when we think about health and access to food, whether someone is staying in the emergency shelter, in the encampment, they don't have access to kitchen or cooking resources. There are sites through the emergency shelter that even having a hot plate in your room can be a reason that you get kicked out, right? So oftentimes people are reliant on the resources that are available in the community to eat and to have health, right? So oftentimes people are going to Loaves and Fishes or Salvation Army that provides, you know, generally a meal a day each day of the week. Food pantries, blue cabinets, SNAP benefits. But again, there's this reliance on prepared food. There's no cooking facilities in a lot of places that people are able to access. And so just to highlight how the social determinants of health and the way that we typically approach them look a lot different when you actually think about what is actually available and accessible for people experiencing homelessness. Finally, civic participation. There may be more in this category that I'm not aware of, so, you know, grain of salt. But there isn't a lot of opportunities for people to participate in our community. There's actually a lot of ways that people experiencing homelessness are pushed away or unincluded from activities because of the way they look or sound or because of just stigma, right, in the community. So there is definitely a need for there to be an expansion of the ways that folks experiencing homelessness can participate in our community as well. So someone took all this together and made the social determinants of health for people without homes. Sorry that it's a little blurry, but essentially putting together what I have been telling you about is that all of these different categories look different for people who have less choice around what is available for them in terms of resources in the community. And often these are also resources that are not made by people who have lived experience of navigating the system. So some of those priorities or the way that their access just might not make as much sense to folks who are navigating our current system. So my main point here is that how we choose to fund and promote access to some of the things that impact social determinants of health, like temporary shelters, affordable housing, health and mental health services, food, and transportation, has a direct impact on the health outcomes of the people who are accessing those services, because that is a lot of what their only option is in terms of getting the most out of those social determinants of health. So for example, funding and promoting access to clean needle exchange can reduce the spread of HIV and AIDS in the community. However, oftentimes that choice to fund and promote access to services like clean needle exchange is not within the hands of the people who are experiencing homelessness or are in need of those services, but rather in the hands of other people to decide what they're going to fund and promote in the community. So just how that's a little bit different for folks. This is a kind of slide that I've put together. And so what we're seeing a lot of locally is that when someone doesn't have housing, they enter our system, which is in its current structure, not very trauma informed, and it has limited options, right? And there's physical health and mental health challenges that are presented from not having stable housing, from not having a place to lock your door, to keep your things behind and your loved ones and your pets, to not have a place to be able to prepare and cook your own food, to not be able to access your previous employment or whatever the situation is. There are mental health and physical health challenges that are presented just by experiencing homelessness in our system. These mental health challenges and physical health challenges, when they are not responded to, can lead to decreased physical ability in one way or another, or increased behaviors that then lead to reduced income, maybe a loss of employment or loss of benefits, that then perpetuates the cycle of no housing. So again, having no housing perpetuates negative health outcomes, just as negative health outcomes perpetuate financial instability and not having housing. There's different spaces where human services agencies kind of have a space to intervene in parts of the cycle, and also places where we need more medical intervention to have an impact on the cycle. So where those social determinants of health are, expanding those options for folks and integrating medical health professionals into the spaces where people are accessing can expand their abilities to have options that improve their health rather than kind of continue the status quo. And we'll come back to this as well. So. All right.
Great. Everybody's still with us. Yeah.
Great.
All right. So briefly, we're gonna walk you through a little adventure in our homeless response system here in Tompkins County for the room. But so what does this look like here in Tompkins County? Like, what does it really look like here? Some people might have more familiarity with this than others. There's a few ways that people who are experiencing homelessness can sort of link in and access a permanent housing destination and support services. One of those, and the one that, it's funny because I'm talking about this, but this is like literally Simone's job. But one of the ways that people are able to access support services and housing is through coordinated entry. So we wanted to talk a little bit about what coordinated entry is and does, and how it works and promotes health, I guess, in some ways. And also a little bit to share about the resources that are actually available in our community, because they're limited, and coordinated entry is one of the places that we bump up against those limited resources, weekly. So this is coordinated entry. Coordinated entry, all continuums of care were asked in like the 20 aughts, to start developing and designing a coordinated entry system to change, to revolutionize the homeless response system from one that was super duper fragmented, where people had to sort of run around to all the million different potential places, go through individual screenings, share their traumatic stories over and over, whatever. HUD said, let's not do that anymore. Let's create coordinated entry, and it would be a centralized hub for people who are experiencing homelessness. A lot of times people think of it as like the housing list in a community, or it's the primary way that people access permanent supportive housing. It does a few things in our community, and we have a pretty our system is working well in our community. We have a lack of resources that the system can refer people into, but the system itself works really well. And some of the things that it works well at is this promoting collaboration, education, and access. So the collaboration piece has proven through the years to be one of the consistently most valuable parts of coordinated entry in our community. We have monthly like case management, care coordination type meetings where people who are on the release and able to engage in conversations are able to talk about people who are experiencing homelessness, update any contact information, say, oh yeah, I'm working with that person now. I saw them here. I'll pass a message, whatever. Collaboration turns out to be super critical in our work. It is often a gateway for meeting new partners. It's a really great way for health partners to link in with the homeless response system. So there are definitely some folks at Cuba Medical trained at this time, and CARS, and Reach obviously is well trained in coordinated entry. And it's a way, it does provide a tool for health providers to say, oh, you're experiencing homelessness. Have you been assessed for coordinated entry? No, let me get you connected. And that's a way that we get to talk to those providers about what resources are available, what leading practices are, all of that. And it is designed to promote access and equity in that it isn't sort of a traditional chronological waiting list where you get on the list and you wait, and when your number is up, you get called. It does have the some amount of flexibility in the way that people are referred based on their health vulnerabilities specifically. So when people are assessed for coordinated entry, one of the things it's looking at is basically a person's vulnerability to death if they continue to experience homelessness. And then people with those higher vulnerability scores are prioritized for available housing as soon as it becomes available. Next slide, please. Right. So this is all the things that I just said. Basically, the idea is people only have to fill out one assessment to become, basically to apply for any available supportive housing options within our continuum. In our continuum of care, the coordinated entry process only refers individuals to housing that is paired with some level of support services. It's not all the highest level of support services, but a coordinated entry referral is always going to be paired with some level of support services. And people are not referred to programs that they're not eligible for, right? So it takes out some of that. If we know based on an assessment that somebody, for whatever reason, it wouldn't be able to be served by the program to which they're being referred, we don't refer them to that program, which wasn't always true in the past. Next slide, please. This is the basics of how it works. So we have the assessment. There's many coordinated entry trained organizations. If you would like to become a coordinated entry trained human being, reach out and Simone will get you trained. So once you're trained, the assessors complete that assessment that I just talked about. There's still the word cat in there. That's an old CE word in there from a long time ago. We enter the information from the screening into our homeless management information system, which is the shared database that homeless response system providers all use here in Tompkins County. And then when there's an available unit for which a person is eligible for, their referral is sent directly to the program, and the program contacts the client directly and says basically like, hey, want a place to live? I wish it was that simple, but that's the dream. Next slide. So these were the available housing projects in 2023. This is important. Take a look at these resources because we're about to show you the available resources now, and you'll see sort of what is happening in terms of access for people. So some of these are still there, you'll see, but in 2023, these are the things we had going on. Pay close attention to those rent subsidies because that's the category you're going to see less of in a minute. Well, everything you're going to see less of. Next slide, please. Here are our available housing projects now in 2024. So these are all the places that Simone could theoretically make a referral into using coordinated entry. Although if you see that there's an asterisk next to the program, that means that that program does have a separate application process, and coordinated entry isn't the only way people are getting referred. Our permanent supportive housing projects are required to use coordinated entry. So that's the only pathway for entry into those programs, but those ones with the stars have multiple entry pathways. So on the left, you see our permanent supportive housing stock, current vacancy. And then you can take a look at our transitional housing and what subsidies we have available. And how many people do we have in the coordinated entry list currently-ish? Sorry, Simone, we didn't plan.
150.
About 150 people. And those are the vacancies that are currently available to people via coordinated entry. So this is one pathway that people take through the homeless response system. You do not have to be in the emergency shelter to be screened for coordinated entry. People who are living, you have to meet the criteria of being homeless. So living outdoors, youth who are couch surfing can be screened. But so this is one pathway through our emergency response system. And then we're going to talk a little bit more. Buckle up for the next slide, my friends. And Simone's going to take it from here about another pathway through our homeless response system.
All right. Hi, everyone. Yeah, like Liddy said, the next slide could be a bit overwhelming, but I'm going to walk you through it. So in terms of where we're at now in Tompkins County, this is like a bird's eye view of what our homeless response system looks like. We have one pathway to emergency shelter, but I'm basically going to walk you through this from the moment that someone exits stable housing. So some of the primary reasons that people have to leave stable housing in our homeless response system include eviction, financial strain, losing a loved one, and domestic violence. Domestic violence is 40% of our population are survivors of domestic violence, and 18% of our population are actively fleeing domestic violence. So these are all huge drivers of homelessness in our community. But oftentimes we don't see that people are exiting stable housing into the emergency shelter. We see that people are couch surfing with either a friend, a family member, someone they know, where they can stay temporarily. And they either stay there for a while, and maybe that starts to impact that person's housing instability. So they need to, look into entering the emergency shelter, or sometimes there can just be a falling out with the relationship. And that person then ends up seeking emergency shelter resources. Again, I'm not like summarizing all experiences of homelessness, but just talking about what some of the most common experiences are. So when people leave that couch, they are brought to the Department of Social Services. The Department of Social Services is the only pathway to be able to enter our emergency shelter. And it's a very high barrier process to enter. There's two major ways that people end up being denied for the emergency shelter. The first is that there's kind of this means testing of, is there another place where you can stay tonight? Is there, the person's couch that you just slept on who said you can't stay there anymore? Could you stay there tonight? What about the person you stayed with 3 couches ago? So there's kind of an intake that you do where you put the last 4 places that you stayed, and they call those people and will ask for you if you can stay there tonight. And if one of those people says yes, then you're denied until that couch is verifiably unavailable. You can also be denied if you're unable to verify your emergency through an eviction notice that you may not have on hand, or if maybe someone doesn't respond. So that is one of the main ways that people are not able to access shelter, is that they're not able to verify their homeless emergency. Another way is that if you're not able to stay at one of those places you were staying, but they'll ask for a bank statement. They'll have you walk down and get a bank statement from your bank, PayPal, Venmo, Cash App, whatever it is. And if you have more than $100 to cover a stay in a hotel that night, then you'll be denied until you don't have the money to cover a stay in a hotel that night. So those are oftentimes when, you know, we're kind of getting looped into a situation. It's people who can't believe that they can't enter the emergency shelter because they can stay on a couch or because they have $300 in a bank account. So it is a very high barrier process, even just to get through that threshold. When you do pass that threshold, and if you are able to enter the emergency shelter, then you are responsible for completing 5 housing search logs a week, complying with substance use treatment if you are suspected of using substances, not if you fail a drug test, but if you are suspected of using substances, you have to comply with substance use treatment appointments, a weekly compliance meeting, employment search, so actively looking for a job, paying 70 to 80% of your earned income if you do have earned income or not earned income, right? If you get SSI or SSDI or any other kind of income, paying 70 to 80% of that income towards your shelter stay, continuing to pass that asset and means testing, and also you can't be in your room between 9 a.m. and 4 p.m. So you can see that not only entering the shelter, but staying in the shelter requires a lot of work every day for someone to be able to make all of their appointments, to be able to kind of fit this, you know, larger societal mold. I think that there's a lot of conversation around, you know, people shouldn't be using drugs and being able to have a free hotel room, or people shouldn't be able to not work and have a free hotel room, whatever that is. I think what people don't realize is that downstream that creates real barriers for people who like may not be doing those things, but now we have to test everyone and present a barrier to everyone every week that they're in shelter for them to prove that they're not doing those things or to comply with those things. So it's really difficult. And that is the only emergency shelter that we have in our system for people to access. After you get into the shelter and you're looking for housing, there's several options for the housing you could look for. You could get on the Section 8 waiting list, which is currently frozen, but generally has a waiting period of 2 to 4 years. So that would give you a voucher to be able to afford housing on the private market. You could go through coordinated entry, which generally takes about 2 months to come up on for your first housing opportunity, but has really limited options, as you saw in the previous slides. You can apply for SSI and SSDI, which can take up to 2 years for you to get that first disability paycheck, but 80% of that paycheck is going to go towards your shelter stay. You still have to save for a security deposit to find a house on the private market, and you're still going to be asset and means tested to make sure that you can't cover the stay of your own hotel room over time. You can find employment to self-pay for an apartment, but again, while you stay in the emergency shelter, most of that paycheck is going to be going towards your shelter stay. You still have to save for a security deposit, and you're still going to be means tested. Finally, there's the SPO process, single point of entry process. So you have to have a severe mental illness diagnosis, and there are several appointments that you have to attend that can take about 3 months to, if you go to those appointments on time. So it can just be a kind of difficult process for folks to navigate, and that's not on the providers at our level, but just what the process is, where you have to have a diagnosis, a verifiable diagnosis, and you have to continually attend appointments. So that's typically what people are working through once they're looking for housing, not even touching on the apartment search and how that's very fragmented, and there's opportunities here and there, but it can be really hard to find the housing itself that's under the threshold of what a voucher will pay for or what you can feasibly pay for with whatever income you're getting. At any of these points, someone could opt to live outside, to live either in the non-enforcement zone that the city has or somewhere else. But in these spaces, you don't have a bed. You often don't have easy access to transportation. You don't have means to cook or have like cooking facilities. There's no trash removal. You can't put out trash and have it picked up. There's no bathroom or sink or anything to wash your hands, and there's no way to shower, right? So you're kind of trading being able to meet those basic needs with dignity or complying with all of these things that you just might not be able to comply with, right? What we do know is that for people living outside, the data shows us that there's oftentimes a higher level of interaction with emergency services. So a higher level of interaction with police, with emergency response. And oftentimes those interactions with emergency services can lead to institutionalization, which then starts people right over with this whole process and the decision making of going to shelter, living outside, applying for different housing options, not knowing whether or not their application has come up on the wait list yet, where do they need to start. So it is a very complicated process and not one that has a lot of options, like genuinely low barrier options for people to be able to have a stable place to get their basic needs met, to, you know, get the most out of those social determinants of health, and be able to achieve stable housing in the future. So this is our shelter. I know there's people on the call. I usually do like a little bit of a pop quiz for folks, but I know there are people on the call who know these places, so I'm just gonna walk through them. This is our shelter. In case people didn't know, you have to access the shelter by that side door in the back that has like the little red thing over it. You click a button, they will look at you on a camera and then buzz you into it. But you can't just like enter the front door of the shelter. You do go down like the side alleyway in order to enter that door. This is the Department of Social Services, another space people are frequently going to stay in compliance for their shelter stay. This is the Econo Lodge. I think a lot of times there's a lot of people get worked up about people experiencing homelessness getting access to hotel rooms, but this is a very basic hotel room. You can't have a hot plate in your room. You can get kicked out for that. So people literally have access to a microwave to be able to, you know, achieve health, which is really what we're talking about today, right? This is a part of the application for getting emergency housing. So again, you have to list the address, dates, that you stayed with someone at that address, and the name and the phone number of the person that you stayed with, and they will call those people to make sure that you can't stay that night when you apply. This is the application that you have to submit within 2 days of entering the shelter in order to access it. I will just send it along. It's linked in the slides. It is very lengthy. It's very confusing, and checking 1 or 2 wrong boxes can be enough for you to have to do it all over again. This is some instructions for people to apply for emergency shelter, just for you to see like the number of steps and the reasons for denial, the pitfalls people can fall through. This is CARS, another space people frequently are. Because this is where people are referred to when they're suspected of needing substance use treatment. So there's a lot of non-compliance issues that can get someone kicked out of shelter. And I just pulled these up here. I don't want you to read the whole thing, but I pulled them up here so that you know that they're like real things and not just like a one-off experience that someone had. But it can be things like failure to look for work, failure to provide a release of information for DSS to talk to your substance use treatment provider about like your compliance with appointments. Voluntarily quitting your job can get you kicked out of shelter. Misrepresentation of a disability, not documenting it appropriately. And essentially, like, these are the things that you can get kicked out of shelter for. It's not focused on like, well, it's not super straightforward, but also it's not like violent behavior or something where you're a danger to someone else or yourself that are the reasons that people, you know, can't access shelter most of the time. It's these different compliance issues that they might not totally be aware of on the front end. In terms of payment for the shelter, so like, why is it 70 to 80%? I would not read through the words that are on the screen because it'll mess up your brain. But essentially what it comes down to is that OTDA does not look at like affordability of the shelter. It's not looking at 30% of your income should go towards housing. What they're looking at is how much money would you need to survive in a given month based on some of the rates of what we understood that people needed in like the mid 1980s. So essentially, you know, if you're staying in a hotel, it's $100 a night, stay there 30 days a month, it's about $3,000. And they look at what income you're making and how much they can use your income to subsidize the amount that they're paying for the hotel. And so they look at how much of your income you're going to need to survive. So for this single man in example 1, that was $45. In this family with a man and 2 children in example 8, that was $238. And they will use the rest to subsidize the cost. Okay, 1997, like that. That was a year before I was born. And then they will use the rest to subsidize the cost of your emergency shelter. So when we look at like how much people are contributing towards their shelter stay, it is usually way too much. There's a lot of people who are sleeping outside simply because they don't want to be charged $800 a month out of their $1,100 SSDI check to be able to stay in shelter and not be able to be in the room between 9 a.m. and 4 p.m., right? And have to do all the rest of those compliance measures. So that. Sorry, it's a little bit of shock and awe today. I'm try to keep it more light and bright, but it's what it is. What does it look like using numbers? I'm just going to go through this really quickly. We are seeing a rise in the number of homeless persons. Don't get too worried immediately. So the difference between the years is the dark blue and the light blue. It is not left and right. So the left, we're looking at the PIC count, which is a single day kind of estimate that we do in late January. And then to the right is our kind of HMIS annual count of people. So a single day versus a year. So you can just see the difference in the dark blue and the light blue and how that number is increasing. So we're seeing an increase in the number of people entering the system, potentially going through those mental health challenges, physical health challenges, and this perpetuating cycle of health and homelessness. We're seeing a rise in 211 eviction related calls. Part of this is because we started becoming kind of a hub for eviction related calls, but also because evictions have been on the rise as well since the eviction moratorium ended. This is what I was talking about earlier, that 40% of our clients are survivors of domestic violence. Of those clients, 41% of those were currently fleeing at the time that this data was taken. So roughly like 17% of people in our system are currently fleeing domestic violence, and 40% of them have a history of domestic violence. So that also just feeds into that pattern of like trauma and mental health challenges and potentially physical health challenges as well for this population. These are some other numbers. So for people who were in the emergency shelter system, only 31% had a positive exit to a permanent housing destination because of those limiting factors and what housing people can access. The median length of stay in shelter was 94 days in 2023. 28.7% of individuals who exited to permanent housing returned to homelessness within 2 years. And we also see a disparate representation of BIPOC families in our shelter and unsheltered populations. Oftentimes, I think there's a conversation about, you know, how many BIPOC people are couch surfing and are underserved in that segment of the population. But the truth is that there's a lot of BIPOC people who are in our shelter who are underserved because our system is underserving a lot of the people who are in it, right? And because there's a disparate representation of BIPOC people compared to their peers in the local population. The last thing that I'm going to bring up is just the relationship between health and the number of episodes of homelessness that people are reporting in the last 3 years. So what we see is that when people are entering our system for the first time, there's about a 50-50 chance of whether or not they're reporting a disability as well. But when people are entering our system 4 or more times, there's an 84% chance that they are reporting a disability on intake, right? So we do really see that cycle of homelessness and health outcomes in our own system, and just people's worsening health outcomes with this kind of ongoing homelessness and lack of financial resources to make choices about their health, about their housing, and everything in between. These are the disability types. So if people have questions about that, again, I just wanted to highlight, so substance use disorder, mental health disorder are some of the disabilities that people are reporting most often, as well as physical health and chronic health conditions. But just a reminder when we're looking at this, that homelessness perpetuates, like homelessness causes substance use disorder and mental health disorder more than substance use disorder and mental health disorders driving homelessness, right? So financial resources are the primary driver of homelessness in this country, not any of the disabilities that are on the screen right here.
We're almost done. I'm going to go really fast because I think people might want questions, and I see that there's 11 minutes. What can we do? Why we talked a little bit about medical providers linking in with coordinated entry. That's totally a thing we can do. But also, next slide, please. Also, we already did this slide once, so I'm just going to, yeah. We brought back the cycle slide. So these are the places where the medical health interventions could occur. I'm not going to go through the slide again. I think the whole presentation got the slide. Our friends at United States Interagency Council on Homelessness have some great information included about health and partnering with health organizations in their federal strategic plan to prevent and end homelessness. This is all linked in the presentation. I strongly recommend, if you're even going to only read one section, do read this section. It's very it makes sense. It will make sense to health providers. Locally, some of the specific recommendations that your friendly continuum of care staff have is to explore the idea of a medical respite type setting. This is something that's part of the 1115 waiver. There's very few in New York State. I think there's 3 total. But it is a model to provide care for people who are medical care combined with an overnight stay for people who are experiencing homelessness and would benefit from a more medical environment than a shelter environment while they heal from whatever that is. Right now we have people with open wounds in our emergency shelter. So that's cool. Also, we would recommend expanding residential or inpatient mental health crisis supports. Currently, there's not any one place that a person who is experiencing a mental health crisis that doesn't reach the level of severity for being admitted into the emergency room or the behavioral health unit, but is too great to be in the emergency shelter space. There really is no space for those folks to go. They are in public having mental health crises because there is no place for them to go, which sort of creates that first responder cycles of institution, all of those things. So we recommend a place. Having medical providers and health providers right on site in the shelter and supportive housing projects. This is something that's been ongoing and we've made progress with, and it's working, right? And then sort of just figuring out expanded options for people to meet their basic needs, and integrating the health care system more fully with all of the other systems we have here. Thank you. Thanks. Yeah, we're open for questions, or I don't know if you have closing stuff. That was a long one. So that was a lot of information. Thanks for sticking with us.
I have a question.
Hi, Sam.
Hi. I don't know if this is the right space for it, but I'll just throw it out there. Well, first, and I have a question, and then I also have a couple examples. I think COC in general does a fantastic job of capturing the realities of someone experiencing homelessness and kind of every step that they must complete and they must stay compliant with. And I wanted to say that, as a service provider that's working directly with this population every day, we see really granular examples of this rollout. For example, the bank account verification, we've seen we've seen many, many people, but I think a good example just for people to kind of process is someone had a really old Cash App account, 4 years old, didn't have access to it, was leaving an abusive relationship, had no idea how to access that account, had to call Cash App, wait for a week for them to mail a letter at an address that they didn't have, and track down this letter, and the whole time had nowhere to sleep and nowhere to go. And so there's all of these little nuanced situations that fall into, and the same thing with kind of verifying people, are you sure you can't sleep on that couch? Sometimes they have to call, sometimes that means that they're calling your direct abuser and asking your direct abuser to say yes, I care about the welfare of this person, or no, I don't. So there's a lot of nuanced situations in there. I guess my question is, for our local DSS, is there a review process that our county participates in to kind of compare our social service access processes to other counties? Is there a way that we can compare the OTDA regs to what we're implementing locally, just so that we kind of have a better understanding of where we stand as a county?
No. But that is a great idea. I think the closest thing, I mean, so at a state level, the New York State Comptroller does like some amount of reviewing of like policy and spending county by county of various DSS programs, but the answer is no. And it's less than transparent how a person would begin.
Yeah, I think the root of that question obviously is that REACH serves folks in other counties, and sometimes those DSS processes seem to be different. And so
Yeah.
I know that it's overseen by New York State, but I would be interested to see the county to county comparison to make sure that Tompkins is doing all that we can do to be low threshold and accessible.
I dig it. You call me when that party's happening and I'll be there.
I don't think I'm the one to organize it, but maybe someday.
Thanks. Yeah.
Question.
Hi.
If nobody else says hi. So I'm with the Tompkins County Human Rights Commission, and we've been working with the Alliance of Families for Justice on homelessness and talking to a lot of homeless people and things. By the way, I'm also the coordinator of the Blue Food Sharing Cabinets, so thank you for that shout out. But my question is, a lot of what we've heard is a lack of what they're calling wraparound services. So somebody gets into a Starry or Our House or somewhere, and they still have the same problems that cause them homelessness, drug addiction, mental health issues, and there's a lack of that when they get housing. It's like they sort of, oh, here's your apartment, good luck. Is there anything that's happening as far as like working on that problem?
Yeah, I mean, there is a gap. There are gaps in our wraparound services that are outside of so the idea of like a housing first program is that it's always going to be paired with those wraparound services. Some of those are going to be community based and some of those are going to be provided by the housing provider, right? So like, we wouldn't expect Tompkins Community Action, for example, or whoever, I guess I shouldn't call out an organization that's not here, to be responsible for treating the psychiatric needs of the people that they're also serving with housing. And the expectation in those PSH programs is that there is enough of those wraparound community-based supports available for folks to be supported in the community so that the housing folks are doing like the housing stuff. But as we see in our community, there is a lack of those wraparound supports. And so everybody, and we see this reflected like kind of all over in a million different ways, but like everyone is trying to do everything. And it results in somehow people getting nothing. And so, yeah, the argument when I get too, like when we get like too far down that train of thought, though, the idea, I'm not sure that we can stop housing people to wait until there are adequate services. I think we need to grow together, right? Because just because that mismatch exists, but the alternative is to stop putting people into available housing while we wait for this other system to catch up with the needs.
It's just that, and this may be anecdotally, but what we hear is that like a Starry and Art House, that they're just disasters. I mean, if you listen to people's stories, it just sounds, and I haven't been, there, so I don't know. But if you listen to people's stories, someone told us recently that they turned down housing in Starry because they went there and there's like needles in the elevator and it's, a nightmare. And then, like I said, this is all, hearsay or anecdotal, but it just seems like you're right. Housing definitely has to be there, but then, how to make it like work.
We have some work, and I know we're right at the end, and I don't know, I didn't mean to talk over Simone if you wanted to jump in. Our committees are doing some work around this with our services second committee. It sometimes feels a lot like reshuffling the deck, right? Like it's a known gap. We say, boy, we really need this thing, and we get together and we try to think about how to do it. And then it also comes down to like those same financial and funding
Sure.
and policy decisions that are being made at like a level that is above the local continuum level, I guess. It's the issue right now. I mean, it's the thing that people are working on, I think, in housing, and especially in supportive housing. But it is not solved.
Thank you.
Yeah.
Do we have time for one more question or comment? A quick one?
I have one, just that you didn't mention one thing that has come up to us, which are people getting out of incarceration. And
Sure.
obviously, when you're incarcerated, you can't start applying for anything and you can't do anything. You're just sort of dumped on the street. And of course,
Yeah.
Alliance of Families for Justice works with that. But just to throw out there that that's another problem. You can't start the process until you get dumped out on the street.
Yeah, that's one of our primary feeders in that buckle up slide. There's a pathway from incarceration, because that is a super common pathway into incarceration. That to me has always felt like a solvable problem, similar to the fact that people's Medicaid gets turned off when they're incarcerated and they come out and there's this gap. I've always been like, we all know this problem exists. This one feels solvable, but we haven't solved it yet as a state, I guess. So, but yeah, incarceration, huge driver of homelessness, really a big part of that health, housing, institution cycle for sure. Because you're doing everything on the street when you don't have housing, which makes you actually more at risk for incarceration. If your whole life is lived without walls around you and people can see everything you're doing, you're more likely to engage with first responders and break rules in front of people instead of in your house.
We're at the top of the hour, and that was a really fantastic presentation, Liddy and Simone. Thank you for being so comprehensive and really accurately painting a picture of what's happening in our county for all of us. So thank you so much. And thank you everyone for coming today.
Thank you for having us.